Hello. Hello, everyone. If you could take your seats, that would be wonderful. Do come down. Do come down. So I know we've got a few people trickling in. We've got a few messages for people couldn't get out of work, which is a real shame. That's, I guess, that's what happens when you have real-life events. You actually have to travel. But welcome to the official launch of the Data Science for Health Equity community. Thank you. Oh, it's so beautiful having people in real life. Anyway, thank you so much for coming. We have turned this event around fairly quickly. The community itself is brand new, so it's really nice to see a room full of real human beings. And we had a lovely number of sign-ups online, so we are trying to run this in a hybrid manner. This is, like many people, we haven't done loads of hybrid events, so apologies if you're online at the moment and there's a technical problem. I'm just hoping that there's not. Yeah, bear with for any problems that happen. So my name is Maxine McIntosh. I'm one of the many organizers and co-conveners of the Data Science for Health Equity community. You'll hear from a number of us this evening, and where we're dotted all around, I'll make them stand up at some point and give us a friendly wave. So the plan for today is a wee bit of introduction from Bria and myself about data science for health equity. Then we're going to make you work, because you have come here in person. You probably come here because it'd be quite nice to meet other people as well. So you'll have kind of slightly structured conversations around challenges to do with data science and health equity, probably solving some really big, important world challenge in a very meaningful way in only half an hour. We're then going to have Sir Michael Marmot joining us, and unfortunately he's only joining us virtually because, as probably given the nature of this topic, you all know COVID rates are pretty high. So he is joining us virtually this evening only. We do have a quick opportunity at the end for a pass the mic. That is an opportunity for you to give an ask to the community, so that could be that you are looking for a new job. Maybe don't do that because it's being recorded if your boss doesn't know, but you're looking for a new job, or you're starting a company and you're fundraising, or you're starting a new project, you're looking for someone to help you with, or you know, anything like that. You have the opportunity for 15 seconds to have your ask to the community. And then between 7:30 and 9, we've got lots of drinks and nibbles. So we've got quite a comprehensive bar of alcoholic and non-alcoholic drinks. We've got deep-fried ice cream, which I largely did because my husband is obsessed with them. And we've got Lebanese wraps and curries as well. So do stick around for dinner and drinks later. So a few bits of housekeeping. You'll hear people say DSxHE quite a lot, and that's because data science for health equity is quite a mouthful. And so when you hear people referring to DSxHE, they are basically saying DSxHE. We're not kind of just sort of sexually harassing everyone in the group. So just know that that's what we say when we mean DSxHE. We've been very clever, and we've renamed the Wi-Fi. So if you want to get on the Wi-Fi, it's data science. The password is health equity. We're on Twitter, obviously, using the hashtag DSxHE hashtag. Obviously, people have, like for many people, actually, this is their first in-person meetup, an in-person event, so please be respectful that, A, some people probably haven't been in a group for maybe 2.5 years. For some people, this might be a bit overwhelming, so just bear in mind that people may be at different levels of comfort in this room. We have some boards dotted around, so please do, especially over there, so please do add comments and write down things about questions and key topics in data science and health equity that you find particularly exciting. Food vans arriving at 7:30, I've done that one. If you are part of the DSxHE organizing group, can you give us like a wave and stand up? There we go, there we go. Particularly tall people are standing up, fantastic. And this event is being live streamed, so if you say something, bear in mind that there's about 150 people online that are also currently watching what you're saying. No pressure. So, what is DSxHE? So we're a community of a mixture of people who really know what they're doing, people who really don't know what they're doing, but we've got experts, enthusiasts, hobbyists, all looking to try and make sure that research innovations and data are there to improve health equity. We kind of had like a wee bit of soft launch in early autumn. We've been growing quite organically since then. So we've got about 1,500 members across the world. Today alone, we've got people tuning in from over 20 countries, which is very exciting. Although someone did say that they were joining in from the sovereign nation of Sussex, which didn't quite feel like it could justify being a country. So as a community, we're still in the process of forming exactly what we do and how we do it. Part of the reason that we're getting everyone together is to kind of hear from you, what would a community of this nature, it's quite specific, quite niche nature be most useful for you, but certainly in the first instance, we're here to define a shared space by which you can have conversations, raise some of these topics. We do lots of curating of the latest papers, resources, events, activities, funding initiatives, you name it. We're quite good at crawling the internet for things that are quite relevant. And we're increasingly going to be organizing more in-person and also virtual events for us to meet one another. I think I'll pass over to Brio in a second, but one of the main things that, in terms of how we're structured is we're structured by these core themes, and these are themes that come from members of the community that they're particularly passionate about. So we've kicked off the community with 4 main themes: genomic data diversity, infectious diseases, social determinants of health, and statistical methods. Yours truly is running genomic data diversity. I work at Genomics England. This is a huge program that we're really interested in. And so if you're at all interested in genomics and data diversity, we're going to be running lots of collaborative events between Genomics England and the DSxHE community on that topic. But just as if you are interested in creating any theme yourself, you are very welcome. You just need to let us know. So I will hand over to Brio, who is both an organizer and running the statistical methods theme. Can we have a round of applause for Brio?
Thank you. So yeah, my name's Brio Lehman. I'm a lecturer at the Stats Department at UCL and also theme lead for the Statistical Methods theme at DSxHE. We also have another theme lead here today, Alicia Davies, who will be one of our panel experts, waving her hand there very nicely. Theme lead for the Social Determinants of Health theme there as well. The last but not least, infectious diseases, Pali Khan. She is an associate prof at London School of Hygiene and Tropical Medicine. She can't join us today because she's doing some very important research out in Zimbabwe. So Maxine already mentioned a bit about what the community is, what the community does, but who is in the community? So we're really a mixture of people, academics, people working in the public sector, we've got policymakers, people working in the private sector for startups or companies, as well as funders, people in the media, and people working for charities and third sector organizations. So we're really just acting as like a big umbrella for anyone who's interested in working to use data science to better understand health inequalities or to promote health equity. We had a little quick stand-up for the DSxHE organizers, but this is the kind of the core team at the moment, plus some really important online facilitators today who the people in the room, you can't see them, but I've heard at least 50 or 60 people who have tuned in online. Hello. And we've got some fantastic helpers, Darcy, Awaz, Abraham and Reham are helping out online. So anyone who's online and has got any questions, just send them over to our wonderful facilitators. So as Maxine said, we've kind of been growing organically since the early autumn. And these are our priorities for the next kind of 6 to 12 months. So we've got our 4 initial themes going, but we really want to grow with some more themes. So if you've got a particular area of interest that's kind of part of your day job and you want to tap into the community to help promote your work, then come and have a chat. We'd really like to launch some new themes over the coming year or so. We also want to grow the community, get more people involved to either build around those themes or just to get people to meet each other, share knowledge around the space of data science and health equity. We've got a few kind of domains of impact around influencing policy and practice, improving the awareness of data science issues, and mitigating risks to health through the deployment of digital tools. And finally, we want to affect change across the sectors that are represented in the community. We're looking for a sustainable funding model, so we're looking for kind of core funding partners to help sponsor these activities. And we're really something which is really important is looking at how can we involve the patient and the public in the work that we do to ensure that it has the impact that we want. And a big thanks to our partners today, Genomics England and the Alan Turing Institute, who have been wonderful in helping us set this up. So now I'm going to pass back over to Maxine to introduce our challenge jam.
If any of you have ever seen a presentation I've done, they're like littered with GIFs, so this was there's no exception. So unfortunately, Gary L. Berman from the Wellcome Trust has become unwell, not with COVID, we think, but unfortunately she's not able to join us, so we only have 5, but 5 perfectly formed challenge poses. Oh, can I have the thingy, please? No, the clicker. Thanks. So each panelists is going to introduce themselves very succinctly in only 1 minute and introduce in 2 minutes a big challenge in data science and health equity. You don't maybe have to remember them all, but you have to remember the ones that particularly pique your interest. If my technical skills have served me well, you should all have an email in your inbox now that has a link to the summary of these challenge jams. If not, maybe let me know in a minute or so. But we're going to hear from each of them where they introduce themselves and introduce a big challenge in data science. So first up, we have Vishal from Google Health, who was running a wee bit late, but he's here, which is wonderful. So come and join us. Sorry for telling everyone you will be late. Vishal was perfectly on time. So can we get a round of applause for Vishal, please?
Okay, hi everyone. Hopefully we can get a chance to chat properly later, but very quickly, a bit about myself. So I'm a doctor by background, so I started with that, did my F1, F2, sorry, I'll sit down if that's okay. And then I was doing consulting for a couple of years, sort of healthcare consulting mostly, and then also started a community called Doctorpreneurs, which is kind of a community of healthcare innovators. So we've been going for about 10 years and just trying to provide resources, education, and a way for different individuals within the healthcare innovation sector to come together to do interesting things. And so that's still ongoing. And then I worked at Ada Health for a few years in digital health, and now I work at YouTube Health. And so what we're trying to do is just to raise up the profile of authoritative health content on the platform, make it easier for people to find that content. So working very closely with NHS organizations and also increasingly healthcare charities and medical journals. And then we're also introducing a couple of product features to make it easier for people to find health information later this year. So my challenge is, in a way, a few different things, but I'm kind of very keen to understand how we can reduce the inequities that are embedded into healthcare education and delivery. So I kind of come up with a few different examples that I've come across through my time in various different things I've been doing. So I do some work with the Royal Free as a governor there, and one of the things that came up in a CQC report a couple of years ago around the maternity services was just the fact that patient safety information leaflets were not available in other languages, and this was causing a big issue in terms of helping patients to understand the care that they would receive or what they should be doing once they go home with their baby. And actually, this isn't necessarily like such a difficult problem to solve in a way, but it's remarkable how little sometimes people think about whether the information that they are producing is accessible, not just in terms of language, but in terms of whether, you know, for those who are hard of hearing, for those who are visually impaired, et cetera, is that information reaching them appropriately, and is it accessible enough? So that's one. So inequitable approach to training doctors. So, you know, there's a much lower 5-year melanoma survival rate amongst Black population versus white people. This was from the Skin Cancer Foundation. There's probably lots of other stats as well. There are a range of reasons, but one of them is a lack of awareness. So actually, there aren't that many images that are shown to medical students, nursing students, around what melanoma looks like in darker skin individuals. And so, you know, that then means that it's not always front of mind when you're seeing patients who've got those types of things in your practice. And then the other one, just finally, is a little bit more in the weeds of clinical medicine, and there's this thing which is called the EGFR, which is basically how you measure kidney function. And it's actually, there is a kind of, one of the criteria used to be that if you were from an Afro-Caribbean population, then you would be requiring a slightly higher you need to have a slightly lower level of kidney function before you qualify for a transplant or before you are classified as having kidney disease. And so actually what happens is that you get delayed diagnoses and you get delayed transplant listing, but there isn't really good, strong evidence for why there was that kind of multiplier applied to this particular metric. It exists for a bunch of other metrics as well. So sorry, I know that's a little bit more niche, but I think it's quite an interesting one. So I mean, I'm just really curious to say, how do we better identify, first of all, these issues, these entrenched inequities, and then, of course, start to rectify them? So sorry, that was possibly a bit long.
No, you're perfect. I might just move closer, intimidatingly closer to you if you're going over time a wee bit. But thank you. So at this point, just kind of ruminate on the questions and challenges that you think are particularly interesting. In terms of exactly what we're going to be doing to address them, we'll do a perfectly formed demo later, just to give you a flavor about the sort of thing that we're after. Right, next up, Sarah Henry.
Thank you very much. Hi, everybody. So I'm Sarah Henry. I'm the Director of Methodology and Quality at the Office for National Statistics. So the Office for National Statistics is predominantly known for population statistics and economic statistics. Hopefully you've all filled in the census. You're definitely following our inflation statistics at the moment. But when COVID hit, we also stood up a really important survey called the Coronavirus Infections Survey. So we did do a little bit of health inequality statistics beforehand, but now we've got a full directorate that deals with that too. So, I move to the next one, green, everything. My challenge is around missingness in data. There's a very good book that I can recommend called Dark Data. It came out just before COVID hit, but as you're reading it, you're thinking, oh, COVID, because actually that's a really good example of something that we had to make huge decisions on without any data to start off with. And even now, 2 years in, there's quite a lot of missing data and quite a lot of really big decisions being made on the back of it. So my challenge is on that, and I think it's particularly important for data science and kind of machine learning type algorithms, because my challenge to you is that if you are developing machine learning and you've got missing data, almost the missingness problems gets worse and worse and worse. So how would you deal with that in your various algorithms? In ONS, we touched on a few examples of inequality. We care a lot about inclusivity. From a methodological perspective as well, because we need to make sure that our research is representative. So what we used to call years ago in statistical theory, kind of representative samples and making sure that our data is representative, we now talk about inclusivity. But we did quite a bit of work on occupation when COVID started, with an attempt to see which occupations are more likely to be exposed and which occupations are more likely to help spread the virus. Occupation is only collected in the census, 2020. We only had data from 2011. And it's a labor market. It's a labor market measure. It's not something that's collected for health. So that exposure to COVID had a big missingness problem. And another one is around ethnicity, which I think is quite a well-known one. And I just mentioned that the Jewish population was hidden in the white population, and it took a bit longer to discover that that ethnic group was more exposed for various different other reasons that are all linked to missingness. So that's my challenge.
Amazing, thank you so much. And if you're sitting there thinking, oh, you know, I'm not a statistician, like that doesn't really matter. So please make sure that you don't necessarily think like one of the challenges are too difficult or too technical, because part of the point is that you need quite a diverse range of ideas and skill sets to tackle these. Next one is Natalie. Oh, Banner. Oh, there you go. Notice when I stand up intimidatingly next to you, please.
Thank you for that particular GIF, Maxine. Not remotely a reference to my hair. Hi everyone, my name is Natalie Banner. I am the Director of Ethics at Genomics England. I am 2 months in, so no, I do not have all of the answers yet about how we can manage and use data ethically and effectively for the participants that we serve at Genomics England. I was previously at Wellcome Trust. I ran an initiative called Understanding Patient Data, and that was very much geared around trying to make the ways that health data, routinely collected health data, was used a bit more visible for the general public and patients and clinicians, a bit more understandable and more trustworthy. So my background is very much around the connection between comms, engagement, policy, and really trying to make sure that decision makers, those who manage and control data, are being responsive to the questions and concerns that people might have about the way their data is being used. And at Genomics England, we're building up the ethics function at the moment, but we really want to try and make sure that the NHS can embed genomic medicine and research in a way that is trustworthy, in a way that makes the best use of participants' data, but really try to anticipate some of the big ethical challenges that come with working with a controversial technology. And that is something I haven't quite cracked yet, but watch this space, I'm sure we will. So, what's my challenge to you? The unintended consequences of trying to do the right thing. We have a community of people here who, I presume, because you've come to a DSxHE launch event, want to do the right thing for various formulations of good, right? Largely, I would imagine a lot of us are motivated and really driven by something to do with public good, public interest, wanting to help the widest range of people possible. And that is a really great intention, and we want to hang on to that. But that good intention can sometimes blind us to the limitations of the data and the tools that we might use to try and develop particular policy outcomes and goals. So we want to do something that is going to be beneficial and helpful. We want to reduce waiting times. We want to increase the efficiency of diagnostics in mammography, for example. And actually, I think sometimes that really good intention can make us not realize that we have limitations in the data and the tools that we might be using to try and get to those beneficial outcomes. So a couple of good examples. You may be familiar with a study that explored the number of algorithms that were developed to try and diagnose and predict the severity of COVID in hospitalized patients. 232 algorithms developed to try and do this. None of them worked. 2 of them showed potential promise subject to further development. So you can see a really good intention there. Everyone wanted to help with COVID, but practically speaking, the tools that were developed, no clinical utility whatsoever. Think of the resource that went into developing those and how that could have been channeled differently. And secondly, an example of an algorithm that was intended to, again, really good outcome, reduce inefficiency and waiting times when scheduling hospital appointments. And actually, the outcome from trying to do this was an inadvertent increase of around 30% in waiting time for Black patients. So, really nice idea to try and improve efficiency, help patients' time, help clinicians' time, but as a result of the way that the data was managed and used to develop a tool, those kinds of outcomes. This is not easy to anticipate, and in fact, these things are blindingly obvious in retrospect once they're out in the world and you can see what's gone wrong. But my challenge to you is, how do you anticipate this? How do you anticipate these kinds of outcomes? And this could be tech solutions, tools, processes, policies, skills. What would you do to try and anticipate these things before they hit the real world and either waste resources or can actually have damaging consequences to people? Over to you.
Never not being really positive, Natalie. We thought we got quite fine just coming through the door today, but I guess not. Thank you for that, Natalie, and never leave your slides with me unattended, it turns out. Next up, we've got Alicia.
Thanks, Maxine. It's fantastic to be here. I'm Alicia Davis. I'm actually from the NHS. So I'm a consultant in public health. And I've worked in health and health equity for quite a long time, but across lots and lots of different areas. I also come from an academic background, so I kind of class myself as a bit of a closet academic. At the moment, I'm the head of research in Public Health Wales. So Public Health Wales is based in Cardiff. I'm saying Wales, the country, not Wales as in the thing in the sea, which sometimes is minuted incorrectly. So Public Health Wales protects and improves, just to lighten the mood a little bit, protect and improve health and well-being, but most importantly, a real focus on inequalities. I'm also, a couple of days a week, working with the Alan Turing Institute, which is a fantastic opportunity, linking with the AI for Science and Government programme. So I'm bringing a health lens into that programme, which is fantastic, and a little blurb there about what we're doing there. So my challenge for you is a big, thorny issue. I'm really interested in the social determinants of health. Maxine mentioned that I'm put forward the social determinants theme. If you want to know about it, just have a look about on the DSxHE website. So health by Michael Marmot, we'll hear later, it's largely determined by the underlying determinants of health, not healthcare, and not some of the other factors that, like treatment and those areas. So whilst data science, AI, transforming, we're trying to transform clinical treatment, risk prediction, all of those things, actually in the social determinants, we're really flagging behind in that area. So my challenge is a big thorny one about how do we bring some of those data science approaches into the social determinant space. So on the right-hand side, left-hand side, over here, this is from the World Health Organization, the WHO. What they did was look at across many different countries in OECD, looking at the health equity gap, so the gap between the in life expectancy between the most deprived and the least deprived, and what are some of the drivers that sit underneath that. So this was looking at self-reported health, and 35% of that difference, the equity gap, is largely due to income security and social protection. You've got 29% due to living conditions and housing, for example, 20% social and human capital. So how do we bring some of those tools into those questions? So the challenge is that is looking particularly at, Maxine's put me off, at examining health equity on individual poverty. Sorry, that's what I'm trying to get to. So the health equity, when we look at health equity in public health, we often look at area deprivation. But there's an interesting dynamic between area deprivation and individual poverty. And individual poverty is really complex, and it's multi-dimensional. So there's fuel poverty, there's food poverty, there's data poverty. Which poverty is worse for your health, and how does one affect the other? And most importantly, what solutions are the best solutions, and who benefits from those solutions if we're trying to address that challenge? So that's my challenge this afternoon, this evening, and I'll leave it there. Thanks.
Perfect, thank you. Maxine put me off. I'm going to slip an H in your bio somewhere next to Wales. Last but not least, Verline L'Espérance. Perfect, thank you.
Hi, so I'm Verline, and essentially I am a academic GP in South London, and I'm also a research fellow at King's College London, where I explore how funding to primary care impacts on patient outcomes. But today I'm here in my capacity as a clinical advisor for the Race and Health Observatory. So essentially, the NHS Race and Health Observatory is an independent expert body established by the NHS to examine health inequalities experienced by Black and minority ethnic communities in England. Essentially, we work as a proactive investigator by actioning evidence and insights and providing evidence-based health policy recommendations and facilitating long-term transformational change in both health and care. We're data-driven and evidence-based, and we look for factual-based solutions. So essentially, here's my challenge. Racial bias in healthcare limits diversity in clinical research and impacts on patient outcomes. Ethnic minority groups are often underrepresented in clinical trials and in research, despite being 1 in 8 of the population and frequently those that would gain the most clinically. Artificial intelligence is being used to increase operational efficiency of clinical trials, reduce costs of clinical trials, and accelerate drug discovery. But how can we use data science tools to essentially drive or influence diversity in clinical trials and research? So that's my challenge to you.
Thank you. Can we give the panel experts a quick round of applause for wonderfully introducing their challenges? Can you have one of the things? So this is where things get logistically complicated, but you're in safe hands. So there's going to be different instructions for those listening online, but I'm going to go through the in-person instructions first. So dotted around the room, we've got these wonderful Challenge Jam templates. Thank you, Maxine. And what we're going to ask you to do is, hopefully you've thought a bit about which challenge you'd like to tackle. And we're going to direct you towards different zones and ask you to come together into teams of around 6 people. So hopefully we'll have like a relatively even spread of people across the challenges. So just to pick the zones now, which I of course had prepared before, we're going to have the missing data challenge in this kind of area here. That's Sarah's challenge. We're going to have the healthcare education and delivery challenge around here. So if you're interested in that, Vishal's challenge, make your way over to this space where I'm standing now. Then Natalie's challenge on the unintended consequences, that will be in this corner right here. And next we've got Alicia's challenge on social determinants. That will be also on the mezzanine, but on the other side near the kind of tea, coffee, bar area. And finally, last but not least, Feline's will be up towards where you got your name badges when you first came in for registration. So hopefully that was all very clear. So what you'll do is you'll have 40 minutes or so, maybe a little bit less, to go through these challenges, come together, have a little chat about what you thought about the challenge and the kind of ways you might want to approach it. And we've got a very easy to use, pretty template with lots of nice pens for you to make it look really, really nice. So I will let people in the room. Is there anything else to add? Oh, sorry, I've forgotten something really important, which is we've got a demo from our fantastic organizers to give you an idea of what a Challenge Jam template should look like. As they're just getting ready, are they ready? I'll quickly describe what's going to happen online as they're just setting up. So online, we're going to set up different breakout rooms for each challenge. So we're going to encourage you to go into the breakout room that you're interested in. They should all be named. Again, we'll have like 2 or 3 breakout rooms per challenge, and try and make sure that we're not going to assign you automatically anything, so you can choose which one you want to go to, but just try and spread yourselves out evenly so that we've got about 4 or 6 people per breakout room. Hopefully that should be clear. If you've got any questions, ask our wonderful online facilitators. I'm going to pass over to one of Matthew or Ellen. Yeah, Matthew.
Hi everyone, so I'm Matthew. I'm one of the organisers here, but in terms of my day job, I'm an Associate Director of Transformation at Imperial College Health Partners. So for the Challenge Jam, one of the ones which I picked was medical education. So to give you kind of an idea of what we're trying to look for, it's not to be super technical, but it's more to try and think through certain aspects of a data science for a health equity challenge. So with that, I thought that you could have some form of online CPD platform and bin some of these medical textbooks, but what that would do is that would sit on a I suppose, a scraping layer from a linked data set. So then you'd be able to start to populate lots of different types of image banks from different races and ethnicities, but then also perhaps start to identify where some of those data gaps may be for bias. So we know, for example, with women, there's a huge amount of non-specific dosages, and actually if we started to fill in some of those data gaps, we might be able to give better outcomes for those women. But I think it's really important that with all of bias and health equity is that we think about all of the protected characteristics and start to plug in all of those data gaps and address some of those challenges. However, with any online platform, one of the things in terms of unintended consequences is around digital inclusion. So we need to make sure that actually the right people have the right access to that source, and that can be a mix of devices, but it can also be around health literacy and so on and so forth. So that's an example of one idea, and then it would be great to hear some of yours for your challenge jams. Over to Ellen.
Thank you, Matthew. I just had to remind myself of the challenge solution that I put forward. So I was thinking a bit about missingness, and I was thinking maybe a good idea would be to create a sort of data influencer role. And I was thinking about a project that happened down in the Southwest. They were trying to improve vaccine uptake, and so they engaged with loads of community leaders and faith leaders. So I was thinking, what if we get in touch with a social media giant who wants to fund a huge piece of work and get people to engage with their own communities and really kind of surface people's concerns about sharing data, what they think isn't reflected in the data that's collected about them. But there are things that we'd need to really be wary of. I guess I was thinking, like, what if, I don't know, groups like sex workers or refugees might be more uncomfortable at feeling a bit more exposed in the data. So I guess pulling together lots and lots of different communities to get into the nitty-gritty of how they feel about the data that's collected about them. And then have a sort of annual congress where 10 years down the line, we can reflect on all the ways in which we've improved health equity, probably have some deep-fried ice cream there as well. And so that was my idea. It's not perfect, a little bit silly, and I think that's kind of what we're looking for.
Cool. Thank you, Ellen and Matthew, for some wonderful challenge jam ideas. So now's the time to jam. We're going to have about 35 minutes for you to put together your ideas. Then we'll have the panel experts will be milling around to kind of, stimulate your ideas, give you a bit of emotional support as well if you need. And then in about 40 minutes, then you'll be pitching back to your respective panel expert. So try and prepare a pitch of around 2 or 3 minutes to go through your wonderful challenge templates. And then we'll have the panel response discussion where we'll have the panel experts reflect on the amazing ideas that you've all come up with. So that's it from me. And yeah, start making your way over to the different areas, which I hope you've remembered, because I certainly haven't.
So thank you for getting so stuck in so enthusiastically. Thrilled to see we've solved the global problems in health inequalities by drinks. Just to be really clear, we are aware that this is a ridiculous exercise. We're not a bunch of tech bros in Shoreditch claiming that we could do that. But I hope you enjoyed the exercise nonetheless and found it a nice way to meet other people. So we are going to do a 1-minute share back. I presume that as we get to the end of the board, the content will get thinner. And that's okay. So what we'll do is, if each of the panelists, experts, is that what we're calling them? These panel experts, sorry, not expert, just on stage. We'll stand up, and can you let me know if you had 1 or 2 groups under your purview? And then you have 1 minute to present. We will be ruthless in pushing you off the stage. And then we will have a bit of a quick discussion before Sir Michael joins us. So maybe Sarah, as you're in front of me, you can go first with your 2 groups. So if you were in Sarah's missing data group, please come forward. The presenter and the the board holder, or you might be the same person. Very impressive. So it's not a competition, but one of you will probably win. So just maybe if you go second, that's a good advantage. So in 15 seconds-ish, Sarah, would you like to remind everyone what your challenge was?
So my challenge was about missing data.
Honestly, if you will do that to me, you make me look ridiculous. Right, I will pass the mic to you.
Thank you. We went on a bit of a wild journey in our group. But essentially, the discussion that we had was... yeah, that is mine. Yeah, there we go.
I'll stand, don't worry about it.
Thank you. Essentially, when you have lots of missingness that is non-random, the best way to get around it is not a technical solution, but it's to try to get better data. And the best way to achieve this is to really invest in trust in the community. So the plan that we came up with is a little bit similar to the sort of things that were rolled out to improve vaccine hesitancy. So have community-based health data champions and embed them in the communities and embed them in schools. And one way that we thought this was, obviously, we don't know anything about how these things are organized, but this could be designed, for example, in collaboration between ONS and the Race Observatory. So try to be engaged with all the communities, not funded privately. I'm not sure how these things would be funded, but perhaps initially a grant that can then be scaled. What else do we have here? Thank you. That's basically what we had. So I think the important thing is that we need to improve trust in the communities rather than trying to engineer solutions to improve data that we don't have. That's basically what we... Yeah?
Where are you from?
Me, Ioana Manolopoulou. I'm from UCL.
From UCL, fantastic.
Yeah.
Can we get a proper round of applause now?
Hi everyone, good afternoon. I'm Joe. I'm a NHS anaesthetist and intensive care doctor and a PhD student looking at data diversity and health inequality. So first thing I'll say is great minds think alike, because we had a very similar idea, and I promise we thought of it first. So we thought about missing data, and there are obviously two potential ways you get missing, or two potential ways to think about missing data. Missing data right now, so data sets that have missing information, and preventing future missingness. And we focus more on the latter of that. So basically, the health data equity aspect is that solutions derived from data might not match your needs. Fundamentally, it's a problem of trust in healthcare usage, so actually accessing healthcare in the first place, so healthcare data is represented in the data sets, but also giving data to the NHS. It's fundamentally a policy problem. Our solution is education, both for NHS staff through proper information governance and regulation so that people can trust them, but also the wider public of the use cases and the good news that can come from sharing health data. We wanted a bottom-up approach, so community-driven, probably partially publicly funded, but with either some sort of private or maybe a arm's-length body, NGO, that sort of connection, so not just purely public money. We wanted to be amazing in 10 years, and a very important thing we're going to do right now is to do a review of health data missingness, see how big the problem is.
I knew that by the time you got to number 7, it was going to get thin. So being amazing in 10 years was the sort of content I was after. Natalie, 15 seconds on your challenge. Please don't do a Sarah.
Okay, so my challenge was around when you are trying to do something good, have a good policy outcome, have a good goal that is aiming to try and improve things for people in some way, how do you ensure you're not accidentally doing something really bad?
Wonderful. How many groups do you have? 2. Right, can Natalie's 2 families come to the stage, please? Very good, very good. Collaborative, I like it. That means that I didn't have to do both of them. Good.
Oh, no, we're first. Okay. Oh, hello. I'm Claire from... Gosh, it's a very loud microphone. I'm Claire and I'm from NI Health.
Hi, I'm Lara. I'm from University of Oxford.
Okay, so our problem was unintended consequences, and the data aspects of this problem, we felt that people are going about with really great intentions of building stuff, but they don't understand the tools that they're building with, and by tools we mean the data tools. So they don't understand the provenance of the data that they're using to build the tools. They don't understand what gaps might be in that data, and we think that's a big problem.
And this is because it leads to basically blindness around the generalizability of your tool and how effective it can be across all populations. So some of the solutions we thought of was, first of all, trying to develop a kind of metric for how good and diverse your data set is. So we think about when we build machine learning tools, it's got to be accurate. Well, now your data set has to be diverse, as well as kind of facilitating that people who build data sets have to list out how they collected it, who was it collected by, so that you have a background understanding, and a TripAdvisor for data sets so people can comment about the cool, quirky things that they found in it, and then that way, when you do follow-up analysis, you can include it.
I think we're out of time, but I'll quickly just say our wider systemic challenges were everything. We need to solve everything before people will do this, but a lot of things around education and diversity and a lack of incentive for people to actually do this. So we need to figure out how to make people excited about being good with their data.
Perfect. Can you round of applause, please? Thank you. And that's an excellent idea, and there's a group called Standing Together that are creating a metric for measuring the diversity of health data sets, so check them out, Standing Together. Go ahead.
I'll pause over there.
Hi everyone, I'm Erin and I work at Accenture in tech consulting.
I'm Josh, and I'm a PhD student at UCL. So in terms of the difficulties in addressing the problem, we felt there were kind of two categories that were outlined on the first presentation. So first of all, it's what are the actual problems with the data? And so we found it was trying to define a ground truth which you use when building models that actually reflects the kind of problem that you're trying to address when it's placed in the real world. And that also, so that's kind of the ground truth, but also the actual definition of the problem at the start, like have you holistically thought of everything that you need to consider? And then secondly to that, it's considering kind of, sorry, yeah, it's very short. Also kind of trying to better work together, not completely siloed working, as we saw with the COVID paper. I'm sorry, I've taken up the entire minute.
So in terms of the solution, what we thought about was, so the COVID paper was really impactful, I think, in thinking about siloed working, wasted resources, duplication of effort. So we thought about creating an online collaborative platform for people to share academic research articles, be able to see what other people are working on, and then be able to post challenges. Don't know how they're going to be funded, but to work globally to solve different challenges without having lots of different people in different places working on the same thing and wasting resources that could be used in other areas of research.
Round of applause, despite being grossly over time. Amazing. We'll do Valine next. So give us a quick summary about what your challenge was.
It was about harnessing data science tools in order to improve diversity in clinical research.
Nice. How many groups do you have? One. One but perfectly formed group. DSxHE, go ahead. Whoa, you've been left out on a limb by your team. Sacrifice her to the masses. Right, beautiful. Perfect. Would you like to introduce yourself?
Hi everyone, I'm DSxHE. I work at Genomics England with Maxine.
Hi, my name's Anastasia. I'm a genetic data scientist at C4X. Okay, so we started by thinking about our challenge and how we can solve it. So I think a big part of what we came up with was measuring diversity and having a diversity index, which is a single metric that can be monitored and communicated to trial coordinators, GPs, to monitor the state of your clinical trials, how diverse they are, and something measurable you can feedback and monitor and improve as you're going along, kind of feeding back into a knowledge base, which again is transparent and available for all and all recorded so it can be used in the future.
Some of the other solutions we proposed were having pop-ups that could go into the communities to facilitate data collection for folks that might not have access to clinical trials. So we identified that as one of the barriers as to why there isn't that much diversity in clinical trials. So financial access, not access to knowledge and education about clinical trials, as well as mistrust. So by going directly into those communities and getting, doing some of the work from a bottom-up approach is a way we would resolve that. And a dynamic real-life dashboard to say how well we're doing, because we're obviously going to solve all of this in 10 years, and it'll be disseminated globally.
Thank you. I find that painfully ironic because Diksha and I work in the same team, and I spend my whole time saying I don't want a diversity dashboard. So that was painful to hear. Thanks, Diksha. We're not doing a dashboard. Alicia, how many people did you have? Teams? One. Again, one but perfectly formed team. Would you like to remind everyone what your challenge was?
Thanks, Maxine. The biggest contributor to health and equity are the social determinants of health. So I put forward a really tricky challenge of how do we better understand and prevent the impact of poverty on health.
Oh, two. It's like you forgot one of your children. It's good that you guys have been collaborating so well. Good, missing data. Right, quick introduction and then go ahead.
Gosh. Hi, I'm Nadia. I am studying public health at Imperial, and we were talking about poverty and health, which is probably one of the biggest... Oh, yeah. I don't do anything cool, it's fine. I'm Alice. I work for the NHS on the COVID vaccination programme. That's very cool. Right? Woo! Yeah, just briefly, we were talking about poverty and health, which is probably one of the broadest topics we could have chosen. So it was very hard to actually distill it down into sort of one solution, but we were talking about kind of what everyone else has been talking about in terms of missing data, incomparable measures, things just sort of not matching up, and how maybe a solution could be algorithms that, gosh, I don't even know. I can't even explain it. Maybe you can. So we talk about decentralized solutions, so taking the NHS out of it and focusing more on local councils. We talked a bit about redistributing data resources and public health resources to areas where it's needed most. And in 10 years, we want to be in a place where there's linked data resources which accurately represent populations and particularly within local communities, and that these individuals are able to access this data as well. And the plan B is to ask Michael Marmot, because we think he might know. Sorry.
Smash it. Round of applause. I feel like times are sad when you say in 10 years you want linked data. Like, that's pretty bleak. Right, but wait, there's not like another group we've forgotten about. Oh, there is one. Oh, sorry, yep. Penultimate group.
Hello, my name's Amanda. I'm a clinical lead for genetic counselling at Genomics England.
Oh, I'm Tom. I work at the Health Foundation.
And we covered some similar things that the other group did, which is helpful. So we talked about that a lot of the issues in this area and the problems are around insufficient access to linked data systems across health and social care. we had quite a nice multidisciplinary group, actually, where some people that work in social care feel frustrated that the data that they take quite a long time collecting isn't then accessible to lots of other people. So, and when you have that, you don't get a full breadth of all the confounding factors that might exist in determinants of health. In terms of our solution, we discussed starting small scale with a pilot project using, potentially leveraging ICSs, or integrated care systems, because it should be in the name that that's what they're doing, so that felt like a good place to start. And if we can evaluate the implementation of that in one ICS as a pilot site, we might be able to learn from that and scale up in multiple ICSs over time. Some of the other solutions we talked about were around tackling that kind of early childhood intervention, whether that's around food poverty or where family education might be key in an early childhood stage. And that some of the wider systemic challenges that this would be shaped by that we'd have to think about in all this is consent and data security when we're bringing data systems together. I'll leave it there. Have I captured it? Yeah, okay. Thank you.
And last but not least, can we get the last team on in expertise in healthcare delivery and education? Who is presenting that? Oh, well done, well done. But remember, don't forget to both introduce yourselves and don't stand under the black orb.
Hello, I'm Orup, a clinician but currently working in startup land. And
I'm Hansel. I work for DaVita International.
Brilliant. So we addressed one of Vishal's many challenges, which is the dissemination of healthcare information and its delivery. So recognizing time limitations, it's a simple who, what, and when situation. We've got a problem with identifying who needs what information because of the systemic biases in data collection and therefore data synthesis, what they need because we don't understand that fully, again, because we have problems with informed autonomy, people giving up their information because they don't know what it's been given up for, and when it needs to be delivered, again, because of problems with access, diagnosis. Vishal touched upon CKD, but there's a plethora of other different clinical conditions where we pick up different demographics and different ethnicities at different times. Now, the problems are centered around who makes decisions, who funds what, and we need to get better representation. So on the journey to getting a better who, what, and when.
Yeah, so there's a few things we came up with, but overall we voted and came to the idea that the grand issue was communication and education between physicians and the people that are building the tools. So the idea that we came up with was to have mandatory training both for physicians and also for analysts that are kind of cross-functional. So essentially creating a buddy system where we could potentially start even in undergraduate education. Physicians are teamed up with people from, say, the computer science or data science departments in respective universities to think of and brainstorm solutions for healthcare projects. So then as they move up in the health system, whether going to the NHS or going into private care, they can keep that perspective in mind as they're building these solutions and as they're delivering care. So much so in recording the data and in building the overall health solutions. Yeah, 10-year plan is hopefully we have some really cool stuff that we built out that helps a lot of people. So.
Sorry, I was busy chatting to people online, and you guys had twice as much time as everyone else. So sorry about that. Thank you so much for that. So Michael is joining us in 8 minutes. So I don't know if any of the panel experts had particular things that they wanted to pull out, or I was thinking we could do a bit past the mic now, have a Q&A after Michael, and then have dinner earlier, because I'm really hungry. Yeah? Okay. Are there any burning things you wanted to pull out, expert panelists, panel experts? No? No? So they're going to ruminate on any profound pullings out they wanted to say, and also they're going to have a look at the online Jamboards and what people were getting up to online. So Michael's here already. Do we make him wait? Should we go now? Would people like a pass the mic now? I feel like there's good energy in the room. Yeah? Yeah, let's do Pastor Mike now. Right, so he can wait until 7. Thank you, Michael. Pastor Mike is, you've got 15 seconds to literally run up on stage. This is not for the walkers or the dawdlers, to give a specific ask to the community. So this is, if you want a new job, you've got a new project you want to share, you've got something up and running, I don't know, whatever it might be. There is no ask. It has to be like slightly related to data science and health equity. It can't be like, I'm looking for a date. But anything other than that is probably up for grabs. It can be a bit daunting, but it tends to be quite high energy and quite an effective way to work out who needs what in the room. And quite frankly, you probably all come here for a reason, so it captures what you want out of it quite quickly. So does anyone want to, Ellen would like to start, right. So it works a lot better if there's a little bit of a cue that kind of starts up here, and then you sort of run off and down. That tends to work. So, okay, there we go. Oh, perfect. Right, you've got 15 seconds, and I will move you off if you take longer than 15 seconds. Right, name, where you're from, you ask.
Ellen Coughlin Health Foundation. I'm running an award with the Royal Statistical Society called the Florence Nightingale Award. It finishes on Monday. Get your applications in. It's going to celebrate people who are doing really excellent stuff in healthcare analytics. Apply.
Hello, I'm Sarah, and I run a blog in healthcare data, and I'm examining the implications on patient care. So if you have a cool topic, please get in touch, and I'm happy to consider your article and collaboration to the blog. It's datacures.co, but please find me after this.
Hi, I'm May, and I work in the Lane Clark and Peacock Health Analytics team. The short version of our name is LCP, and we've just launched our postgrad internship program. So if anyone is completing their postgraduate degree toward the end of this year and are interested in signing up or want more details, please speak to me or look online at LCP.
Hi everyone, good afternoon. I already said who I was, I'm not wasting my time doing that again. So I'm Joe, PhD student, working on a Standing Together project. Thanks for the plug. Come and chat to us. We're all about data diversity, improving data quality. I'm around all evening.
Cool, hi everybody. I'm Leandra, I'm a master's student at Oxford, and I'm looking for a PhD in, basically I want to computationally minimize social bias in health data. All right.
Hi, you all know me already. So we have hundreds of vacancies at ONS for analysts. Check out civil service jobs and ONS jobs, I think, on Twitter.
Hello, I'm Claire. I'm part of One Health Tech, which some of you might know because someone here might be involved in it. But we are doing a campaign at the moment called the Health Tech Toolkit, which is looking at understanding and reducing barriers to professional development for people from underrepresented groups. We're looking for people who want to pick up a project off the back of that and do that. So if you're interested, come and talk to me or get involved in One Health Tech. And also, we run a London hub. We do monthly meetups. Come along and chat to us. It's very nice. Lots of people here have been to them. It's great. Sorry. I was going to pitch our Health Tech Hinge idea, but...
I feel like it's just me between Michael now. I'm Vicky. I work at the Alan Turing Institute as a community manager. We have a partnership with Roche, and we're running a seminar on the 25th of April on missing data. So please sign up. Just search Turing Roche Partnership.
So I'm Matthew from Imperial College Health Partners, but we work very closely with North East London ICS. We have a massive linked data set which covers in social care, primary care, secondary care, and we've also done some work with urban health on wider determinants. If you want to come and play around with data and know about more, please get in touch.
I'll just take the liberty. I run a program at Genomics England called Diverse Data. We're going to be recruiting like hell across bioinformaticians, program managers. We haven't got hundreds of posts because we're so competitive to get into, but plenty of the team are here. So if you want to know more about how fun it is to work at GEL, then just meet the really lovely people who work in the Diverse Data team. And without further ado, we finished the Pass the Mic. So congratulations and well done on doing that. That was hopefully quite an effective way to meet people. And I don't know what happens now technically. Hal is just giving us a thumbs up. We just go for it.
Thank you, Maxine. So it's my great honor to welcome Professor Sir Michael Marmot to our community launch event. I don't want to eat into much of Michael's time. Maxine has made him wait long enough already. So I'll keep this introduction short. Michael is, of course, the director of the UCL Institute of Health Equity, and really the leading expert in health inequalities, not just in the UK, but globally. He's the author of several books, including The Status Syndrome and The Health Gap, and also the author of a number of influential reports on health inequalities, again, not just in the UK, but in other countries also. He's a recipient of multiple prestigious awards and a mind-boggling 19 honorary doctorates. And I still haven't mentioned Michael's most impressive achievement. Back when we soft launched about half a year ago, Michael kindly agreed to our community request to be the Data Science for Health Equity team mascot. So I'm sure he's incredibly proud of that. Thank you, and I'll pass over to Michael.
Thank you. I thought when you said my proudest achievement, you were going to refer to my 2 tiny grandchildren, but there we go. Data Science for Health Equity. After one of our reports, one government official said, this is ideology with evidence. We could have an interesting conversation as to which comes first, the ideology or the evidence, but they're closely interrelated. Can you show the slides? Or do I do that? Yeah, good, next. In 2010, we published Fair Society, Healthy Lives, the Marmot Review. And in evaluating what happened after 2010, the data are absolutely critical. So rather than say, I like the government, I don't like the government, they're nice people, they're good people, they're bad people, or something else, let's look at what happened. Next slide, please. And what happened was not great. Life expectancy, which had been increasing about 1 year every 4 years for 100 years, in 2010-11, slowed dramatically. Wow. If you'd been a government that had had the ambition to slow down a 100-year improvement, you'd be pretty proud of that. You might doubt whether what we did it, but it certainly happened. And that's one of the problems of this is not a controlled experiment. Next slide, please. And the inequalities increased. What we've got here is the least deprived decile for women for different regions. And for the least deprived, the regional differences are quite small and life expectancy improved a bit. For the most deprived, life expectancy improved in London and went down for virtually every region outside London. So before the pandemic, life expectancy had more or less stopped improving, inequalities were getting bigger, and health for the poorest people was getting worse. Next slide, please. And if we look at the regional differences in a bit more detail, this is London and the Northeast. The Northwest would look similar. For the least deprived 10%, there's very little difference in life expectancy between London and the Northeast. As deprivation increases, the disadvantage of being in the Northeast increases. Or to put it another way, you take the index of multiple deprivation, a national index, and it's more predictive of shorter life expectancy in the Northeast than it is in London. And the dotted line is the earlier period, the solid line is the later period. You can see life expectancy improving for London right across the gradient, but going down for the poorest decile and the next decile, and not really improving for the bottom 6 deciles in the Northeast. Next. And then came the pandemic. People said at the beginning it would be the great equalizer. I heard a voice of ONS. I'm a great fan of ONS. They've done a brilliant job throughout the pandemic. Next slide, please. This is ONS data. And you can see that the social gradient in all-cause mortality, the dark green, and the social gradient in COVID-19 mortality are really very similar. So yes, we're right to want to control the virus, but what about the inequalities? I was talking to a group concerned with oral health, dentists. Next slide, please. And did I not put it in there? Oh, I'll come back to it. So we've got this social gradient in COVID-19 and in all causes. And the question is, do we deal with this as a social or a medical problem? And the answer, of course, it's both. Next slide. The opening line of my book, The Health Gap, was why treat people and send them back to the conditions that made them sick. So we need to deal with the conditions that made them sick, and we need to deal with the specific health outcomes. Next slide, please. And so that gets to the point of disease control or social determinants. So I was jumping ahead of myself. Next slide. This is the slide I just showed you a moment ago. And as I said, I was talking to dentists, next slide, and showed them this slide, the social gradient by deprivation. You can't read the heading. Next slide. A gradient in dental caries in 5-year-old children. It looks like the social gradient in COVID-19. Next slide. I was talking to a group concerned with prevention of cardiovascular disease in primary care, and I showed them this slide. It looks like the COVID-19 graph. What's going on? COVID's caused by a virus. Dental caries is caused by diet, low fluoride, poor dental hygiene. Obesity is caused by diet, lack of exercise, stress, but not by a virus. So yes, we do need to control the virus, but the idea that all we have to do is get vaccination and then it's all solved is quite wrong. Well, we know it's quite wrong. Look at the epidemic we're going through at the moment of Omicron variant. So we need to deal, and the data show us this, we need to deal with the underlying inequalities. Next slide. This is a kind of litmus test. When I said that the data and the ideology go together, people on the right politically say inequalities, it's all a matter of individual responsibility. People on the left say it's society. What does the evidence show? Next slide, please. If people followed the healthy eating guidance, those in the bottom 10% of household income would have to spend 75% of their income on food to follow that guidance. Is this lack of individual responsibility? Absolutely not. Don't blame the poor, blame their poverty. At the other end of the scale, if the least deprived choose to feed their children Coca-Cola, they are irresponsible. So yeah, irresponsibility, personal responsibility is important if you've got enough money. But if you have insufficient money, it's the poverty that's the issue. Next. Targeted or universal. The classic position in Britain of social policies, we target the worst off. A more Nordic approach is universal social policy. Next, we tried to put them together and talked about, next slide, please, and talked about proportionate universalism. Universalist social policies with effort proportionate to need. Next slide, please. Here's a thought. We could call it leveling up. So social distribution, less deprivation, higher life expectancy, for example. To deal with the gradient, you can't focus only on the worst off. So we said universalist policies with effort proportionate to need. What did we get after 2010? Next slide, please. This is spending by local government per person. The dark bars is total local authority spending per person. In the least deprived 20% of areas after 2010, the spending per person went down by 16%. And then the greater the deprivation, the greater the reduction. In the most deprived 20%, the spending went down by 32%. What we've got here is effort inversely proportionate to need. The greater the deprivation, the greater the need, the greater the need, the greater the reduction in spending. Next slide, please. Central action or local? Next. Child poverty, defined as less than 60% median income after housing costs in 2009-10 was 27%, and that went up to 30%. Next slide, please. How did the government achieve that? This is changes to the tax and benefit system after 2010 by household income. The red line is working age families with children. If you were in the poorest 10% of household income, as a result of changes to the tax and benefit system, your income would have gone down by 20%. In the next poorest decile, it would have gone down by 12%. And then the richer you were, the less the reduction. Some reduction at the top, but nowhere near as big as the percentage reduction at the bottom. Government policy was to make poor people poorer. And the data are absolutely crucial. Next slide, please. So I said central or local. We do need central action to reduce child poverty, for example. But we've been working in localities all around the country. Coventry declared itself a Marmot city. We produced a report for Greater Manchester, Build Back Fairer in Greater Manchester, Luton, Waltham Forest. Next slide, please. Cheshire and Merseyside, Cumbria and Lancashire, areas all around the country. But if you look at excess mortality during the first wave of the pandemic, that is, how many deaths from all causes would you have predicted based on the previous 5 years? In the first wave, England and Wales, or England particularly, had the highest excess mortality of any country. Then Wales, Scotland, and Northern Ireland. In fact, I've literally seen data this afternoon that if you look at the life expectancy decline among rich countries, the US had the largest decline from 2019 to 2021, and the UK had the second largest decline in life expectancy. If you're in New Zealand, if you were South Korea and managed the pandemic well, you didn't get a decline. And the reason I think that we had such poor health performance before the pandemic and such poor performance during the pandemic is potentially fourfold: poor governance and political culture, the increasing social and economic inequalities, the reduction in spending on public services, and the fact that we weren't very healthy. So I would say, coming out of the pandemic, building back fairer, we need to pay attention to the specific recommendations I made in my 2010 and 2020 reports, but we need to address these issues: poor governance and political culture, the increasing social and economic inequalities, the reduction in spending on public services. My number one is put a fair distribution of health and well-being at the heart of all government policy. Thank you.
Thank you so much, Michael. I'm not sure if you could hear the round of applause that was in the room just now.
Could you do it again so I can hear it, please?
You're also getting virtual round of applause on Zoom, which I'm not sure if you can see, but again. So we've got time, I hope, for a few questions, which I'm going to try and manage from the Zoom chat as well as in the room. So if anyone's attending on Zoom and would like to pop their questions in the chat, then do go ahead. And I'm actually going to start with one from the chat while the people in the room formulate their questions. So first off, we've got a question from Darcy, who's currently studying for an MSc in digital biology at the University of Manchester. And Darcy asks, if we're aiming to direct effort proportional to need, how do we measure that need in a way that avoids the issues with means testing, such as that means testing itself being a barrier to the most deprived?
Yeah, it's a good question. Means testing is the way that I'm saying we shouldn't just be doing, which is targeting the worst off. But for example, the index of multiple deprivation is not a bad measure of need. As I've shown you, it's intimately related to life expectancy. It's even more strongly related to healthy life expectancy. Now, we measure need in the NHS as clinical need, and it's a universalist system with effort proportionate to need, but I'd like to measure need socioeconomically. And the index of multiple deprivations, not a bad start. We could also look at education. But the other issue that COVID alerted us to is ethnicity, and that's vital. We know the very high risk for Black British, Black Caribbean, Bangladeshi, Pakistani, and to a lesser extent, Indian. So I want us to look at need in social terms, not just clinical medical terms.
Okay, thank you. Any questions from the room?
Hi, Michael. Quick question around one of the graphics that you showed. I believe it was the child, the percentage of the income that's spent on healthy eating based off of the UK requirements. There was a large difference between those who were classified under 1 and 2 for the deprivation index. Do we know why that happened? Because the deprivation index is made up of a large number of sub-factors, and they're all weighted quite differently. So is it because,
That's a good question. Those data come from the Food Foundation. And in fact, in a subsequent report, perhaps for the reasons that is behind your question, they combined the two bottom deciles. So they did it by quintiles. They thought that it was perhaps a bit unreliable for the bottom decile. But even if you do it for the second bottom decile, it's still a high proportion. And other data show that when you look at the basics, the lower the income, the greater the proportion spent on food, on rent, and now, of course, on heating, home heating, which means there's less money to buy new trainers for your children or to have birthday parties or other important things.
Thank you. We've got another question from the chat from Eleanor Law of the ONS. Eleanor asks, what additional data should we start collecting or acquiring to be able to direct resources to where they are most needed?
Well, I mean, my own view is that the ONS index of multiple deprivation is not bad. It doesn't, of course, provide a complete causal explanation, but it's not a bad indicator of where resources are needed. I mean, just to give you an example, there's a program called Be Well in Manchester. It's surveying school children on well-being. And David Gregson, who's the inspiration behind the program, was discussing the data with me. And I said, what have you got on poverty, deprivation, or whatever? He said, well, not much. We asked people. I said, geocode it. Just look at the neighborhood and classify neighborhoods by degree of deprivation. And I'll bet I know how it comes out. So he did it. He showed the data in Manchester Monday of this week. there it was. The greater the deprivation, the worse the psychological well-being in school children. So it's a pretty potent predictor. It's not bad. And it gets away from targeting the worst off. I mean, despite the answer to the previous question about household income decile, it's not bad. And it's very graded. And the fact that you know, somebody says, I've got this new set of data on child well-being, and I say, look at the index of multiple deprivation, and by golly, there's the gradient, exactly as predicted. So it's pretty robust.
We've got one question in the room here. And then we'll have one from the chat.
So a little bit more on the kind of policy side of things and how you ultimately might be able to engage with politicians. I was wondering what your views were when you try to reason with politicians that might take the existence of outliers in data as a general rule. And I'm thinking particularly looking at, you know, individual responsibility angle. So the fact that maybe some people might manage to, say, kind of buy healthier foods on lower income might kind of, in a way, prove the point that you could do it. So I was just wondering how you try to navigate that difficulty of people not necessarily kind of understanding that an outlier is an outlier.
Yeah, I'm sure you've heard, as I've heard, they're usually ladies with posh accents who say, I could cook perfectly well on a low budget. These people are ignorant, they just don't know how to cook. And I could show them how they could live perfectly well. And I say, when was the last time you read Jack Munro's blog? Read what it's like to be a single mother on benefits and trying to keep your head above water. And then how helpful it is to have some posh lady say, I'd be able to live on that. When you're trying to decide, you know, and I've talked to people in this situation, you're trying to decide, can I buy a can of tomatoes to have with that dry pasta that I just bought? Could I afford to have cooked pasta and have a can of tomatoes to flavor it? You know, we're talking about Britain in the 21st century. Please don't give me a lecture about individual responsibility for people who are trying to decide whether they can afford a can of chopped tomatoes as well as dry pasta. Now, I think the off-diagonals are really interesting. I mean, so to take a different measure, early child development, if you look at the percent of children age 5 that have a good level of development, it shows the expected gradient, the greater the index of multiple deprivation of a small area, the smaller the percent of children age 5 with a good level of development, but they scatter around the line. Some areas are doing better than others for a given level of deprivation. And that's really interesting. That's not just individual responsibility. It's saying what predicts why some do better than others. And it suggests to me not that we should ignore deprivation. That's one axis. Reduce the inequalities, the social and economic inequalities, fine. But then try and understand why, for a given level of deprivation, some are doing better than others. And for example, we know that Bangladeshi kids do better for a given level of poverty than white kids do. Hey, that's really interesting. What is it about Bangladeshi families that are having a more positive impact on their children's outcome than in poor white families? And Black Caribbean look more like the poor whites. The Bangladeshis look better. So I think we can learn a lot from that. And that's going beyond just the link with deprivation.
Thank you. I think we've got time for one more question, if it's a quick one from the room. There is one in the chat from Bing Wang, who's an EPR Senior Configuration Analyst at the Great Ormond Street Hospital. And Bing asks, how can we ensure that digital How can we ensure digital health inclusion for the deprived communities? For example, people without good phone data signal coverage or might not be able to afford a smartphone to get their up-to-date access of healthcare records.
Yeah, let me answer it at a slight tangent. When the digital divide was being documented in education, the fact that when the schools closed down, poor kids were extra disadvantaged because they didn't have access digitally, and kids from greater privilege had iPads and better internet connection, and their schools were giving them, English at 9 o'clock and maths at 10 o'clock and so on. And the cost of buying every kid an iPad, every kid who was more disadvantaged, was relatively trivial, would have been relatively trivial in the context of what we were spending in the pandemic. We could have solved it. We really, really could have solved it. And I was looking at UNDP data globally, and the huge difference in digital access and its relation with education. And again, it's a soluble problem. It really is a soluble problem. It takes some money, yep. But given the billions we were spending during the pandemic, that's one we could have solved, and we still could.
Thank you. We'll end the Q&A there, and I'm not sure if Michael will be able to hear the round of applause that everyone will be giving him in the room, but I assure you it's not a deathly silence. So let's all thank Michael for his wonderful talk.
Thank you. My pleasure.
Great. So to finish off, I think Maxine wanted to take over. Yeah.
This is the end until now dinner. So if you were to open these doors, you'll be met by two lovely food trucks, the Calm Indian and Beirut's, for a little curry and a Lebanese wrap. If you want to go straight for dessert, you could go for teppanyaki ice cream, which my husband will be. And there's a bar fully stocked with alcoholic and non-alcoholic drinks. So please do stick around. We've got the space until 9. I presume you all came here in person because you'd like to meet other people. So please do stick around. For those of you who are online, we are going to be doing Zoom breakout rooms that randomly shift every 15 minutes. Lucky you. So that is our best attempt at trying to recreate a little bit of an opportunity for you to meet other people who are still online, but I'm afraid we weren't able to ship you snacks. We do have a board with just some questions that we as the organisers would like to ask you, so that's just on the left over there, so please do, Ellen is beautifully demonstrating it. She also wrote it with her beautiful handwriting, so please do post your kind of answers and observations on that board over there. And last little thing, so if you enjoyed tonight, you obviously did, right? We have a monthly thing called The Download, which is where two people come together and share an article or a podcast or a video that they found particularly interesting in data science and health equity. Half the people who turn up haven't even read it or look at it, but you have a kind of open discussion about that provocative piece on data science and health equity. So please do come to the next one, which is on Tuesday at 8 a.m. British summertime. We've also got a Slack workspace. Again, if you just look at our website, www.datascienceforhealthequity.com. It's in the footer, so please do join the Slack workspace and chat to us. We are very much on the lookout for people to start new themes and lead new themes. So if you have a particular area of interest, I highly recommend doubling up with your day job and things that you could really benefit from collaborating with other people across the community on. And we're also looking for other partners, be it for people to host events with us, to support themes, to be a core sponsor. We're kind of open to everything. Just come and chat to us. So next slide. Next slide, Bria. Thanks. Cool. So these are our faces of the organisers. So we're dotted around the room. So if you've got any questions about data science for health equity, you want to learn more, you want to even be an organiser, obviously, none of us look as photogenic as these photos, but we're very excited. Actually, Wale, who was based in Nigeria up until about 2 days ago, has come specifically, I think, for this event. So everyone go speak to Wale and appreciate his dedication to this. And if you've got any questions, mine and Brio's email is at the top. So yeah, thank you very much for coming, and have a nice drink and food.